Good morning. I am really delighted to be here. My name is Tracy Battaglia. I am a practicing primary care physician scientist who has dedicated her career to safety net settings where I deal with patients who we've heard about all morning, where cancer diagnosis is not necessarily the worst thing that they're facing in their life. And my academic career has been focused largely on the science of patient navigation. So I want to start with a sincere thank you to the National Cancer Policy Forum for acknowledging patient navigation as a high priority area for us to be thinking about. I think the timing is right for us as a nation as we're transforming our healthcare delivery systems. So to shine a light on a promising program like patient navigation, this is the time to be doing it. So I'm thrilled to be here. What I'm going to do is share with you some work that's innovative and exciting and just getting launched in the city of Boston. It is called Translating Research into Practice, and it is a true community-driven navigation collaborative. I'm not sure how to advance.
Just press the
green button with the big green arrow. Thank you. So I had the privilege of being part of the NCI-funded patient navigation research program. We were one of the 9 sites across the country that provided data for the national study. And so the Boston PNRP program demonstrated, as Dr. Pasquet alluded to earlier, improvements in both diagnosis and treatment. And in Boston, we concentrated on breast and cervical cancers. There's a picture there of the healthcare system that we studied patient navigation in Boston. And for those of you who are familiar with Boston, we have multiple healthcare systems in the city of Boston. The Boston HealthNet system, which was the site where we conducted the PNRP program, is one of many. But it is the integrated healthcare system that serves as the safety net for the city, and so it's the majority of sort of low-income, racially, ethnically diverse populations. So we demonstrated impact in that one healthcare system, which was fabulous, because there was such a need in that population. And as a result of that, as well as other research that was going on in the Commission on Cancer Standards, there was a sort of dissemination of navigation programs throughout the city that developed independently across each healthcare system. And there are multiple, but let's just say for now there are 6 different healthcare systems. As a result of that, those of us who were doing the work met regularly. We had regional navigator meetings, and we met to share best practices. But there was tremendous variability in the implementation of these programs across the city, in very large part because of sort of the various funding mechanisms that the health systems paid for their programs. And there certainly was no shared patient-level information that was happening across these healthcare systems. And much to our dismay, in 2014, there was a seminal article by Hunt and colleagues that demonstrated persistent and, in fact, widening disparities between blacks and whites in breast cancer outcomes. And they looked at the top 50 cities. And unfortunately, Boston was in the top number 5. So it was at that point that we sort of looked at each other and said, wow, what are we doing wrong? And so in 2014, a group of us in the city of Boston came together to develop what is now known as the Boston Breast Cancer Equity Coalition, a true community-driven, multidisciplinary stakeholder group that got together because we share a common goal. We want to eliminate differences in breast cancer outcomes by promoting excellence in care among all women in Boston. The group includes members from nonprofit organizations, government agencies like the local and state departments of public health, all the institutions in the city who provide care, patients, advocates, policymakers, and researchers. There's about 30 of us that come together on a quarterly basis in person to talk about what are sort of high priority areas for us to come together to develop citywide solutions with the specific goal of eliminating breast cancer disparities. And so we looked at our local data to try to understand where was the opportunity. And for those of you who know the screening data in Massachusetts and in Boston, we do a darn good job of getting people in for screening, and specifically for breast cancer screening. And so there are no disparities in breast cancer screening and mammography screening in our population between Blacks and whites. But if you look at our state level data, there is persistent disparities in treatment. And so this group got together and developed a program that we call TRIP, Translating Research into Practice. And Dr. Pasquette set me up nicely because she demonstrated that there is a gap in sort of research in this area. And although we are focused on breast cancer, we are going to fill some of that gap by doing an innovative dissemination and implementation science study. Our goal is to improve the delivery of timely quality breast cancer care among vulnerable patients in Boston through a coordinated care delivery model that includes 3 evidence-based tools that we know, if implemented according to the evidence, can reduce cancer disparities. The first is a patient navigator network, not just a patient navigator working in isolation, but a patient navigator working within a navigation system within their healthcare system, but the innovation here is across healthcare systems. The second is, in order for navigators to do their job well, they need a registry or a tracking system to identify their patients who are most at risk for delays in care. And the ability to share that registry across health system is an innovation. And the final is a platform to both screen for and refer to barriers that are related to the social determinants of health. I think all of us in our healthcare systems are seeking innovations in how we can do this so that we can address the burgeoning social determinants of health for our low-income populations. And the ultimate goal is to eliminate care delivery disparities in this breast cancer population, but not only that, to serve as a model for other locations and other diseases. And so we are working very hard at utilizing a dissemination implementation science framework so that if and when we are successful, we'll able to utilize this information to pick up and to bring to other healthcare systems and other diseases. Because of our community-led initiative and because of our translational sort of approach, the National Center to Advance Translational Science, NCATS, which supports the CTSAs, the clinical translational science agencies across the country, has supported us for a cooperative grant to conduct this study. So my final slide just demonstrates the multiple stakeholder engagement that we're utilizing to conduct this study. Our funding just began this fall. It is a multiple PI program. We are working together because we need all of the resources at all of the CTSI programs in Massachusetts, both at Boston University, Tufts, the Harvard Catalyst, and UMass. Our clinical partners are 6 of the healthcare systems in Boston that care for over 90% of our at-risk populations. You are eligible for navigation in this program if you are non-white, or you are white and you have another vulnerable risk factor like having public health insurance or not speaking English. We cannot do this without strong community partnerships. So the Boston Breast Cancer Equity Coalition is the driver for this project. The Pink and Black Patient Advocacy Program that's supported through the Boston Public Health Commission are strong partners and will be continuing to work with us longitudinally throughout this project. There is a network of patient navigators in navigation programs in the city of Boston. We plan to utilize that network to guide our work throughout the conduct of this study. And the Chicago CTSI is working with us from the inception so that we design something that is applicable to other healthcare settings outside of Boston. Chicago happens to have a lot of the same challenges as we do in Boston, but also has many of the same infrastructure, including multiple academic medical centers and an active community coalition. So we are conducting a large pragmatic clinical trial. This is not a randomized controlled trial. This utilizes innovative methods to do research in real-life settings. And so our hope is after several years, we'll have around 1,200 women who are enrolled into this study. And in the end, we hope to demonstrate reductions in care delivery disparities for women with breast cancer, but also have tools that are disseminatable outside of breast cancer and outside of Boston. So I look forward to coming back to share with you the results of our study when we have them. Thank you.